My name is Linda Feldbrugge. I'm a surgeon at Charité in Berlin, and I would like to share with you our findings on the safety and feasibility of robotic liver resection after previous abdominal surgeries. These are my disclosures. In recent years, numerous case reports and observational studies have reported advantages of adding a surgical robot to minimally invasive liver surgery. However, more studies are necessary to specify in which cases robotic surgery has an actual significant advantage over conventional techniques, and especially as the cost is still high and the availability is limited. It also remains to be defined if there's any specific contraindications for robotic surgery or liver surgery. One common concern in any type of minimally invasive surgery is the fear of peritoneal adhesions from prior surgeries. We could previously show in a retrospective analysis that in conventional laparoscopic liver surgery, previous abdominal surgeries do not present a risk factor for more complications or for longer surgeries. With this study, we aim to investigate if the same is true for robotic surgery. This analysis is part of a single-center post-marketing observational study that was supported by Intuitive Surgical, with the overall aim to investigate the safety and feasibility of robotic liver surgery as this new technique is established at our center over the last few years. In this sub-analysis, we compared the short-term outcome parameters of patients who reported previous abdominal surgeries with those who did not. We included 126 cases of robotic liver resection. About half of them were major resections, and the median Iwata score of surgical difficulty was 8.5. In most cases, patients were diagnosed with colorectal liver metastasis or HCC. And you can see that the majority of patients, 59%, reported prior abdominal surgeries, and 41% did not. For them, it was their first operation. When we compare these two groups of patients with and without prior surgeries, the baseline characteristics were similar. We did, however, observe significant differences in the rate of liver cirrhosis and the underlying pathology, the tumor that led to the surgery. Not surprisingly, patients who had undergone prior surgery were more likely to be diagnosed with colorectal metastasis, liver metastasis, because of the resection of the primary tumor that often happened before. And also, they're not unlikely to receive multiple successive liver resections in case of recurrence. On the other hand, patients with no prior surgery were more likely to have primary liver tumors such as HCC and cholangiocarcinoma, which also makes them more likely to have liver cirrhosis. We then went on to specify the type of previous surgery that the patients reported. And we saw that about half were upper abdominal, half were lower abdominal surgeries, and about half of the procedures were done in a minimally invasive technique, and also a third of the patients had multiple prior surgeries. When we compared the two groups with regards to the perioperative outcome, we saw no differences. The length of surgery, including the consult time, the conversion rate, the transfusion rate, and also the length of stay in the hospital and on the ICU were all similar. The fact of previous abdominal surgery did not have any effect on the postoperative outcome, on the postoperative complication rates. Now, you could argue that some surgeries cause very little trauma and might not have a visible effect on the subsequent robotic liver surgery. So we performed some subgroup analysis and defined specific groups of prior surgeries that we expect to have the most impact on peritoneal adhesions and on subsequent robotic surgery. These were procedures in the upper abdominal region, as is depicted in the figure, and we also selected patients who had prior open surgery, as this is known to cause more adhesions than minimally invasive surgery. We also looked at patients with prior liver resection. And then finally, we defined a group of major resections or major surgery, where we excluded all procedures such as cholecystectomy, hernia repair, appendectomy that can be considered minor procedures and are unlikely to cause any adhesions. We analyzed the same outcome parameters as before, and we always compared this subgroup of major impact surgeries with the group of patients who had no prior surgeries. We did not see any significant differences, except in the group of prior liver resections, where we saw a longer duration of surgery. To minimize the effect of possible confounding factors, we also performed multivariate analysis, including all factors that differed between the two groups, including the underlying tumor, the rate of liver cirrhosis, and the BMI that tended to be higher in the group with no prior surgeries. Here we see the multivariate analysis with the length of surgery as the dependent variable. On the top, testing the effect of all prior abdominal surgeries. On the bottom, just the prior liver resections. And we see that the effect of prior liver resection on the length of surgery that we saw in the univariate analysis before is likely to be confounded by the factors of the underlying tumor and the presence of liver cirrhosis. Both factors are independently associated with the length of surgery. Surgeries in patients with liver cirrhosis are shorter, and not surprisingly, the length of surgery, robotic resection of cholangiocarcinoma is significantly longer than in the case of colorectal metastasis or HCC. We performed the same multivariate analysis to test the effect on postoperative complication rates, but I did not include the results as there was no significant effect of any of the factors. So in summary, we have shown that prior abdominal surgery does not lead to longer surgeries or more complications in robotic liver surgery. We conclude that robotic liver surgery should always be considered irrespective of the history of previous surgeries. And we would even propose that the robotic technique might have advantages over conventional laparoscopy in cases with extensive adhesions due to more freedom of movement and a better vision. Thank you for your attention. Please feel free to contact me for any further questions or discussion.